which is again to share a knowledge and sensitize about the rare diseases. As we know in our country, the incidence is rare, but as a whole, that there are lot of incidents. And we have an expert here, Dr. Tupan
Yes,
Kanti
yes, yes, yes.
Dolai. So
Good
welcome.
afternoon.
Actually, when I saw your resume, it's like it might take the whole session to introduce about your expertise. It's an honor and privilege to have you with us and introduce you to our participants here. Dr. Professor Tupan Kanti Dolai. He is a professor and head of a Department of Hematology from Neelratan Sirkar Medical College and Hospital, Kolkata. He has about 2 decades of unwavering dedication and clinical excellence, academic teaching, and lot of research in this hematology. He is from premier institutions. He has done his DM in clinical hematology, MD in general medicine, DNB in medicine. He's also a fellow of Indian College of Physicians and Indian College of Hematology. He has a lot of credits, gold medals, best thesis awards, and he has given multiple orations across. I have displayed his CV here, and he has lot of publications and research. And he's now a current honorary secretary of Indian Society of Hematology and Blood Transfusion. Sir, over to you to give your insights about the PNH, which is a very rare but extremely important topic to discuss and to improve the quality of life of those individuals and families with PNH. Over to you, sir.
So, thank you very much, everybody, and thank you for this introductions. So, it is really privilege to give this opportunity to talk on this the organization of the rare diseases. So, this the rare disease is always a rare, but the problem is that it is not so rare because our knowledge is limited, and that's why we are unable to diagnose the patient. That's why it is a rare disease. And the important thing is that in the rare disease, the certain definition is there, but if we consider it, it is not so much rare in the obvious reasons. So today the topic of the discussion is the paroxysmal nocturnal hemoglobinuria is there. Can you go to the next slide, please? So in the PNH is the next slide.
Yes, sir. Yes, sir.
I think it is not moving.
Yeah. Just a minute. Sorry for this.
So, in terms of the PNH, the paroxysmal nocturnal hemoglobinuria is a type of the acquired disorder we face in our day-to-day clinical life. In this, the PNH usually when the patient presented with a hemolytic anemia like the anemia and the jaundice, then subsequently the doctor and the physician, particularly the specialist hematologist, they do lot of investigations. And the PNH is one of the differential diagnoses we call the Coombs negative autoimmune hemolytic anemia. So in the layman's language, if the patient has a anemia, if the patient has a jaundice, along with patient has a recurrent history of the exacerbation of the anemia, then the PNH might be the possibility. And the PNH, the problem of the PNH is that sometimes there is the cola color urine in the morning. The cola color urine in the morning because into the night, usually the pH of our blood is false. That lead to the activation of the complements, and this complement give rise to attach to our RBC and leading to the hemolysis. This is the main pathogenesis of this disease that give rise to the destruction of the RBC, and RBC destruction that leads to the formation of the urine like a cola color, or sometimes the layman's language you can call the red urine. If this kind of things is happening, this is called the classical PNH presentation called the hemolytic PNH. Apart from that, we have another variety of the paroxysmal nocturnal hemoglobinuria that is called the a plastic PNH. In that, the PNH, apart from patient has a anemia, that might be the problems of the low WBC count, there is a problem of the low platelet count, and along with there is a clone of paroxysmal nocturnal hemoglobinuria is there. So this PNH is a life-threatening disease because if we go to the mortality and the mortality of this the PNH, there is a chance of the premature mortality is there. In terms of the statistics, they have been suggested that the 0.13 per lakh population and there is a prevalence is 1 to 5 year prevalence is also become less. And the majority of the people, they are dying within the diagnosis of the 4 to 5 years. Please share the slide.
Yes. Yes, sir.
So majority of the people, they usually die on that due to the hemolysis. And apart from the hemolysis, there is a thrombosis is the characteristic feature of the PNH. Sometimes the people may develop the thrombosis within the abdomen. There is a thrombosis within the vein and the artery. And sometimes the rare cases, they may have a thrombosis in the central venous system that is called the CVT. That CVT may be the one of the presentation of the paroxysmal nocturnal hemoglobinuria. Apart from that, sometimes people may present it also in the features of the acute renal failure. So these acute renal failure lead to the increased morbidity and the mortality. So the statistics have been suggested that around the 20 to 30% people will die within a 5 years despite of transfusion, corticosteroid and a lot of anticoagulation. So they are using. Go to the next slide. So the thrombosis, the renal failure, and there is a severe anemia is the main problem. As I already told you, that the complement activation is the main culprit of this, the activation of the disease. Next, please. So that lead to the PNH. In the PNH, this complement activates and ultimately the membrane attack complex, which is called the complement 5P9 and the complement C5 will become activated. It lead to the intravascular hemolysis and that lead to your leukocyte reactivation, lead to the thrombosis, the platelet elevation lead to the thrombosis, and due to the generations, the scavenging and the reduces the sensitivity, that lead to the smooth muscle dystonia. That's why the sometimes patient presented with the dyspnea, the dysphagia, the erectile problem, and abdominal pain, and also the chest pain. And I already told you, if the patient has a recurrent thrombosis, if the patient has a recurrent chronic renal disease, the patient might be land up with a chronic renal failure. Sometimes the people may present it with the features of pulmonary hypertension and also the liver disease. So these are the consequences and the complications of the paroxysmal nocturnal hemoglobinuria we seen in our day-to-day clinical practice. Please, next please. So you know the membrane attack complex that is called the MAC. This is called the C5, and this MAC is becomes very important in our the defense mechanism, because any organism or any infection is there, our complement systems become activated, and these complement systems will try to get rid of our infections. So this complement is our essential part of this disease. So in that cases, that this the terminal complement activations that lead to the intravascular hemolysis and leading to the this disease we call the cell destruction, thrombosis, and certain types of the inflammation within this the internal organ is the main pathogenesis of the disease. Next please. So to classify the disease, usually depending upon the clone size, we usually divide it. That is the classical PNH that we call the hemolytic PNH. Here the clone size is more than 50%. And apart from that, there is the other manifestation is also there. That is we call PNH in the setting of the bone marrow failure syndrome. In that cases, you have get a plastic animal-like picture. You will get a multiple myelodysplastic like a picture is there, and usually clone size is more than 50%. And there is a subclinical PNH is there called the clone, usually seen in less than 10% of the cases. There is a no development of the intravascular hemolysis. But in general, the classical PNH is a common, and there is a PNH in the setting of bone marrow failure syndrome is the another entity. Next, please. So the diagnostic criteria is there. algorithm, when the patient refers to us, they usually presented with the features of anemia like weakness, dizziness, fatigue. There is a thrombotic event, I already told you, there is a cola color urine, dark urine, there is a pain in sometimes there is features of dysphagia is there. So in that scenario, we usually investigate by the common thing, the complete hemogram, reticulocyte count, the LFT, and also we do the Coombs test. So our suspicious is the Coombs negative immunohemolytic anemia. Then we order for the PNH testing. Nowadays we usually do the flare testing and also by the flow cytometry based testing. And the old testing like the sucrose analysis test and also the HAMS test become obsolete nowadays. So we usually prefer to do the flow cytometric based assay. Then we diagnose that patient has a PNH. After the diagnosis of the PNH, if the other cell line is involved, then usually we do the bone marrow examination, bone marrow aspiration, and the biopsy we usually do. Next, please. So if we consider that the complement mediated hemolysis is the main problem of the disease, more chance of increasing mortality is there. If the patient has a LDH is very, very high, there is an increasing risk of the complement mediated hemolysis and also the death of the patient. Next, please. And also, if you consider that the elevated PNH in the one registry of the South Korea, their suggestion is also that there is a probability of the survival is also become affecting by the PNH in comparing to the general people. That in the PNH group of the patient, their survival is less. If you consider there is a survival in the 30 years, it is around 20%. So this group of the patients, they are dying and due to this, the hemolysis and LDH marker that can predict that there is a chance of mortality there because it causes the hemolysis and the marker of the hemolysis. Next, please. So for this the algorithm of the PNH, as I told already, there are two types of PNH, one is hemolytic PNH, another is the plastic PNH. So in the plastic PNH, you usually look for the aplastic anemia, the aplastic myelodysplastic syndrome, and other bone marrow failure syndrome is there. We have to do that if the patient has a plastic anemia and the myelodysplastic syndrome. We usually go ahead with the stem cell transplant. If the patient has a moderate aplastic anemia along with the hemolysis, if the patient has hemolytic PNH, so in that scenario, we usually give C5 inhibitor to treat the disease that will prevent the thrombosis of this patient. Similarly, there is a German guideline is there. They are suggesting that if the patient is asymptomatic, we can follow up with the supportive care. Sometimes the prophylactic anticoagulation has to be given if the clone size is more than 50%. And the symptomatic cases, there might be the hemolytic crisis. There will be the supportive therapy leading to the blood transfusion. If the patient has a hemolytic, we give to other therapy. Sometimes steroid may be effective. And in case of the thrombosis, we have given anticoagulant. But the more important thing that either of these cases, you need the definitive therapy. The definitive therapy in these cases is usually the C5 inhibitor. Next, please. Next, please. Next slide, please. So in terms of this, the monitoring that majority of the cases we monitor for that by the flow cytometry. If it is negative, we are repeating either 2 to 3 years. If it is positive, we are going ahead with the treatment. Next, please. Next, please. Next slide is. Next slide. So in terms of the anticoagulant therapy, because anticoagulant therapy does not prevent it, and in terms of the stem cell transplant, if you offer for the treatment of the disease, that by giving the stem cell transplant, you can able to salvage the patient around 50%, but the transplant rate is very, very less, and it is the only curative form of the therapy, because in the transplant group of the patient, that the conditioning regimen and the selectivity and the center for doing this PNH in the transplant is becomes less. So that's why there is a limited role. Next, please. So that's why there is a treatment recommendation for the both PNH with plastic anemia is debated. Sometime in case of more PNH clone, then there is a chance of giving the PNH-based therapy. If the patient has the plastic anemia that's positive for the PNH, sometimes immunosuppressive therapy may be given. If the patient has a hemolysis dependent, then there is a guideline for giving the C5, the inhibitor is there. And if the patient has a severe bone marrow failure syndrome, we go ahead with the stem cell transplant. Next, please. So there is a drug that C5 inhibitor we call the eculizumab. These are the eculizumab development history starting from the pilot study, the phase 1 study, there is subsequently phase 3 study. There is a lot of the study have been doing in this group of the patients starting from the NEGM very early 2004, then come to the TRUM study. All have been published in the prestigious journal, then come to the SEPHA study and also the AGC study, both into the eculizumab. And all the study, they have been enrolled around 187 patients across the group, and there is a long-term extension phase also there in this eculizumab development. Next, please. Next, please. This, I already told you that the eculizumab blocks the terminal complement activation by inhibiting the C5, that is called the membrane attack complex. They become responsible for the main problem of this, the complement activation mediated hemolysis. Next, please. So this next please. So the eculizumab act on the C5. Next please. How it is doing that this eculizumab bind the high affinity of the C5, then terminal complement the C5A and the C5B9 blockade, and this the proximal function of the complement remain intact like the weak anaphylactic immune complex clearances, microbial obstination might be there. Next please. So these are the action of this eculizumab. Next slide please. So this is the STRUM study, phase 3 study. Next, please. So here there is a inclusion and exclusion criteria is there, and in this group of the patient, LDH is the important marker, and the drug have been given usually the 1 to 4 week, that is the 600 mg has to be given. IV weekly, then come to the weekly 5, there is a 900 milligram IV single doses. Then come to the every 2 weeks, that has to be given. Next, please. This is the baseline characteristic. This is the match study, so there is no problem. Placebo control trial. Next, please. So it is well matched. And in terms of this, the hemoglobin and reduction of this requirement that by giving the therapy of this, the PNH compared to the placebo, there is a significant stabilization of the hemoglobin, decreasing RBC requirement, and also the decreasing chance of the hemolysis is there by giving the eculizumab. Next, please. So this TRUM study have been clearly demonstrated how by giving the eculizumab, we are reducing the hemolysis. That this Kaplan-Meier survival suggested that the LDH level is become going down by giving the therapy. It's suggesting that there is reducing the hemolysis. Next, please. Similarly, it causes the transfusion independence also. The transfusion independence becomes improving by the eculizumab comparing to the placebo. So there is a transfusion free. Next, please. So in terms of the reduction of the fatigue and the health improvement quality of the life, that has become very, very important. That eculizumab has become superior compared to the placebo by improving the quality of the life also by reducing the fatigue. Next, please. And in terms of the adverse event, you go that the placebo and the eculizumab, there is no major things is there, but you have to remember that the respiratory tract infection is the concern that has to be keeping in the mind, particularly the nasopharyngitis and the headache is slightly more in the eculizumab arm than the compared to the placebo, but there is no statistical significance. Next, please. Serious adverse event is more or less the comparable, no major problem is there by giving the eculizumab. Next, please. Next to conclusion is that this phase 3 TRUM study that demonstrated that eculizumab has effectively, depending on the transfusion, dependent the PNH, stabilize the hemoglobin level, it reduces the transfusion frequency, and it associated with the improving the quality of the life. With the more common adverse side effect is that headache, nasopharyngitis, back pain, and the nausea. And but there is a they are consistent with across the all studies. So there is no major side effect is there. Next, please. You see the safer study is there. Next, please. Next. So here also the similar kind of thing they have been given. The you go to the design also the same. Next, please. And it is the more or less the similar group of the patient. Next, please. And also in terms of your the reducing hemolysis becomes significant comparing to the placebo. Next, please. Next, please. So the transfusion requirement is also improving, fatigue also improving. Next. Side effect is more or less similar in the study also. Next, please. So to conclude that it is the more or less similar, the safer study and the stamped study is more or less similar in terms of conclusion. Next, please. So the long-term safety and the efficacy of this eculizumab is also have been studied significantly into the PNH. Next, please. So if you go to the long-term extension phase of this, the CLAM study and the safer study. Next, please. At the baseline characteristic is more or less the similar in the both the group. And in terms of your the significantly complement mediated hemolysis is less in this study. Next. And transfusion also it is clearly significantly reducing it. And in terms of this, the reaction is also less regular. Next, Joe. Next, please. Next, please. Renal dysfunction also improving. And also the long-term survival is become improving comparing to the normal. Next, please. So the important cause of mortality is only 4. There is no significant. One patient has a myelomonocytic leukemia, another is stomach carcinoma, and one patient has a hemorrhage. Next, please. So the long-term safety is there. There is no major concern is there apart from the headache, nasopharyngitis is there. Next, please. Next, please. So there is no long-term problem is there. So concluded that this eculizumab by the 13.3 months data have been clearly tell us that it is the significant reduction of the intravascular hemolysis, the thrombosis, and also there is a reduction of the hemolysis and improvement of the CKD. There is a mild side effect is there like headache, nasopharyngitis, and upper respiratory tract infection. So it improving the overall survival around the 97% patient they are surviving for 3 years. Next, please. This is the conclusion. So thank you very much for hearing. So to conclude that this the PNH has a significant mortality and the mortality is there. And in terms of the PNH, the drug is eculizumab is there. It becomes improving the overall the morbidity and also the mortality and near normal life. With this, I end here and happy to take few questions. Please stop sharing.
Thank you, Dr. Tufan, for this extensive knowledge sharing on PNH. You took us through the basics of PNH, the treatment, the management options, the outcomes, and how it has really improved the quality of life. I request the participants to post their questions in the chat box so that we will discuss with Professor Tufan. Sir, in the meantime, I would like to know, is there any difference in the diagnosis of different types of PNH?
The difference is that the plastic PNH, you have to do the bone marrow biopsy. The hemolytic PNH, you have to do the PNH testing like the flare and the flow cytometry.
Okay. Sir, it's like also the eculizumab is there for the treatment, but is there any other options? What is the cost involved using this?
The cost is there. If we consider the bone marrow transplant, the cost is single time cost is around 15 to 20 lakhs. if we consider the eculizumab treatment, there is a cost is there. So I think the cost is involved, but the more important thing is that it improving the morbidity and mortality.
Okay, okay, sir. Sir, and this is like with respect to this PIGA mutations, is there any variation in the clinical
A
phenomena?
lot of the mutation is there, but I think this is not clinically relevant, and we are not testing regularly for this the mutation. But yes, they have some relevance, but it
Okay,
is not clinically the things that we really do the each and every patient. So it is experimental basis.
okay, okay. Sir, this one, what is the mean age of diagnosis, sir? Usually,
Usually in the third and fourth decade in our scenario.
okay, okay. So, is that any early diagnosis has any significance on their improvement of quality of life?
That is very important. You have to do the testing early and diagnosis very early, then you can improving the quality because before the development of renal failure, there is a cerebral problem, thrombosis. If we diagnose early, I can treat that will improving the quality and the morbidity and mortality.
Okay, okay. So, like we saw about the South Korean National Registry, is there any registry for PNH in
Yeah,
our?
I think PNH registry is not there. We need to formulate the PNH registry. So you people can take in the lead to do the registry.
I think we request your guidance also because you are the one who deals with the patients on a regular basis.
Yeah, I think you have to work on that issue across the country by involving the lot of the stakeholder and jot out the different diseases and make a registry.
Okay, okay. Sir, I mean, though as we discussed, it's been rare. Do you think the awareness is very important for PNH?
Yes, yes, yes.
Okay, across.
Awareness is very, very important from the physicians and also the hematologist.
Okay, okay. So,
So I think if there is no question, we can call for the day.
yeah, sir. Again, one more thing is that there is one question from Thamal asking to share your experience, personal experience.
We did this the eclozumab trial, and I think this eclozumab trial, the patient is doing very well. We have been giving these drugs, and also the side effect is less, and there is no major adverse effect is there, and hemolysis is significantly reducing. The transfusion also becomes significantly reduces. So I think this eclozumab is the drugs. It is fantastic drug that can help really to the quality of life of the patient with PNH.
Sir, with respect to this X-linked basis, even though it is X-linked, there is also that females are getting affected more or equally in PNH cases actually. So,
Yeah, I think it is both the sexes usually show in the PNA. There is no only sex predilection in there.
oh, so what is this incidence as of now in India?
Sorry?
What is the incidence?
Yeah, incidents we exactly don't know. That's because there is no registry is there. There is no data is there. This
Oh,
area is seriously lacking.
okay, okay. So thank you so much.
We have few questions from the audience. It's posted in the Q&A section. Uh, Dr. Indhumathi, if you can take it forward from there.
So, sir has already shared. There is one question being here, Praveen sir. So, uh, Professor Tufan has already addressed it. It
Okay.
will take
Thank
us some more time to. Sir, maybe uh, Professor Tufan, can you just share about how to take about with the registry for PNH and
Yeah, I think for the registry, you people should take a lead. You try to involve the several hematologists across the country
okay.
and try to make the registry, jot down the different patient profile. Then only this will become possible. So you need to contact the stakeholder who is taking care of this patient.
So there is also one more question from Mr. Amit. How good is the effect of small molecule drug like Laptocopen in
Yeah,
comparison?
I think the ectocopen is also the another drug that really improving the degree of the hemolysis and also reducing this transfusion requirement and also the other thrombosis related problem, the kidney problem, the CVT. This is another exciting drug also become using in case of this the PNH. But I think this drugs is not yet available in India.
Okay. Sir, when usually do we consider BMT for these PNHS cases?
See, usually the BMT we usually do in the patient with the PNH. Usually in case of the aplastic cases we do that. And apart from that, if the patient has a hypoplastic PNH, and if the patient has a severe hemolysis, if your the clone of the is more than 50%, so in that cases we have to also do these things, the transplant.
Sir, how can we make it, to diagnose it at an earlier stage? Most often, as you said, it is in the fourth decade or so. But how can we make it to establish an early diagnosis for PNH?
The early diagnosis, you need this only the awareness generation among the physician and the hematologist. If the patient has a hemolysis, anemia, jaundice, then you have to order for the test. Then only it is possible to diagnose early. So awareness is important among the physicians.
Okay. So I request Praveen from ORDI to share his thoughts about.
Thank you very much, Doctor, for your valuable time and giving us a better understanding of the PNH. A lot of our patients also have been going through these challenges and were looking at some insights on these aspects. Thank you very much for your insights on this topic, Doctor. Uh, so,
Thank you so much, Professor Tupan. It was really an um, ice-breaking talk, actually, that we have covered everything about PNH and about the recent the trials and the outcomes and the patient improving his quality of life also. I'm so thankful for your time and your knowledge sharing. And we here would also like to share this rare info series happening every Saturday. We have one upcoming in May 3rd, which is again on familial hypercholesterolemia. We request all the participants to be part of this as well. And thank you all the participants also for being here and making this uh, um, a more interactive session with your questions. I hope this was useful to you as well. Thank you. Thank you very much.
Yes, thank you, thank you.
thank you, Doctor.
Thank you. Thank you.
Thank you.
With this, we end our session for this week.
Thank you very much. And we look forward for the next week for a session on familial hypercholesterolemia.